Good afternoon, everyone. Not yet started. This is the beginning of the session. Voice is clear and audible to all of you. I can see a lot of friends here. We are around 100. We are very near to 100 candidates in this room. So I'm really proud and very happy to see all of you again. And the people, somebody knows me, others not. So in summary, my name is Mohamed Hassan. I'm a lecturer of MRCOG Part 2. Hello, Vani, everyone. Samreen, of course, my friend. Madiha, yes. Noor, yes. Thank you all. And I'm a lecturer of Part 2, MRCOG, and an examiner of Part 3 in the college. And I'm a lecturer of different courses in mid-exam experts for more than 8 years. So I'm welcoming all of you. Today is the first session in progressive course, and you need to know what is the aim of this course. Okay, the aim of this course is refine your knowledge and explain how can you manage questions in the exam, because there is a big difference between the knowledge and applied knowledge. Okay, so the knowledge, all of you can take it from the books, from guidelines, or from a regular course. But in progressive course, we will be so much focused about how to apply the knowledge. We will, of course, try to explain many points during discussing questions, but still the main aim of this course is to know how to read questions, how to analyze the data, okay, how to analyze the information given to reach the correct answer by the least effort. And this is the game, because people are sometimes saying that exam is very difficult. Questions are very vague. It's never like this. Exam, MRCOG exam, is fashioned for trainees. It's not an exit exam. It's not an exam for consultants. It's for trainees. What does that mean? It means it's a standardized exam just to assess and evaluate your standard knowledge. Okay, so I'm not starting sharing any screens yet, Dr. Seema. So I'm just giving you some intro information. So what I would like to say again is it's a simple exam, but you need to catch the point. Every question in this exam carries keyword, maybe more than a keyword as well. The problem always that candidates sometimes are not able to see this keyword, and then they will never reach the correct answer. Our mission today and for the next few weeks is to revision. Okay, it's like not like the revision. No. Revision means reopen your mind regarding better vision to see the questions from another perspective. Okay, today I chose two silly and difficult topics. The oncology and urogynaecology. Why they are silly and difficult? Because they are not regular practice for trainees. Okay, yeah. Now the MRCOG UK NHS trainees, they used to do labor ward, antenatal care, most of obstetric scenarios. In gynecology, they are familiar with benign gynae. They are familiar with fertility problems. Few of them are usually practicing different surgical core scenarios and techniques, but rarely they are dealing with oncology stations and urogynecological patients. That's why it makes this, these two topics very specialized topics. And today we will tackle both of them through multiple questions of EMQs. Let's start, just to save time. We have questions of EMQs in oncology and urogyne. So I would like to start with the first one. It will be, I think the urogyne is available right now. Let's start.
So we're not seeing any slides, sir. We're not seeing anything on the screen, sir.
If you just waited for a few seconds.
Okay, thank you, Dr. Hassan.
Thank you, my friend.
What a wonderful lecture. Wow.
Thank you so much in advance. So let's start reading the question and think about the possible options. Okay. Now, while you are reading the question, I will revise with you few important things regarding the knowledge. So for the first question, before start answering the question, by the way, my advice in exam is to, when you are reading the EMQs, you have to skip reading the options. Read the scenario first, okay? What is the headline of the question, and start reading the scenario. You have to put maximum 2 options in your mind, okay? Don't start reading the options unless you are confident enough in one option coming to your mind, or maximally 2 differential diagnoses. Because if you start reading the options first, you will find everything. So you will be confused and lost at some point. While it's better to follow this strategy rather than reading the options. In the first question, a patient, okay, for each urodynamic report, select the most appropriate diagnosis. This is the head. So we are looking for a diagnosis. A patient with a residual volume of 150 milli was noted. Stop. Once I read this information, I have to analyze it. What is the aim beyond this information? It seems like they are pushing me towards voiding difficulty. Okay. Again, residual volume after evacuation should never exceed 50 milli. Once it's 150, it seems like there are some sort of obstruction or voiding problems. Keep it in your mind. Okay. During the filling phase, no abnormal pressure raise. Okay. It means this case typically not overactive bladder. And as well, there is filling with a volume about 500 milli urine. With this volume, please remember that the maximum bladder capacity varied between 300-400 to 500-600. So this is a very normal volume of the bladder, which is impossible to be like this in overactive bladder. In overactive bladder, the bladder muscle is very sensitive to any distension by urine, irritation by urine. So the patient needs to evacuate very early with a little volume, definitely less than 300. So this sentence equal overactive bladder, detrusor instability out. Okay, out. Now, let's continue. Urine leakage happened within the second cough. Stop. This is a picture of classic stress urinary incontinence. During the voiding phase, the maximum flow rate was 12. Now, again, they are giving you additional information regarding the voiding problems. The voiding problems. So if you are going to choose an option, I have to choose a urodynamic stress incontinence with typical voiding difficulty. So I will go for G. Excellent, people. Now, what about the second scenario? Let's follow the same technique. Don't just read the scenario like you are reading a newspaper, okay? Just try to analyze single information. Mrs. Green, urodynamic results showed she has initial residual volume of 9 milli, okay, 90, and first desire to void at 140. Her maximum capacity seems to be normal, within the range. During the filling phase, the trouser activity is seen, which increased with tap water, but not with cuff in supine position. It means that we have some queries regarding the trouser overactivity. All of you know that we are evaluating the trouser pressure in the filling phase, not in the voiding phase. Next to that, despite, please take care of this, she did leak a little bit urine during repeated coughing in the erect position when the pressure is higher, in intra-abdominal pressure as well. So it's matching with stress urinary incontinence. Now I'm really confused. I'm really confused. Some of the picture matching with OAB, the other symptom matching with SUI. I have to keep reading. She had a keel and forceps delivery 10 years ago. It seems like this information pushing me towards SUI more and more. Then has urinary leakage on standing and straining mostly. Again, SUI. She also wakes up at night few times to go to the toilet. Nocturia is again matching with OEB. So I will catch the stick from the middle. I will go for mixed incontinence, mixed urinary incontinence. Okay. I'm looking for a mixed urinary incontinence in options. Oh my God, this option is not available. So again, I need to reevaluate my mind. Now let's analyze more in depth. What about the maximum capacity? I can conclude a lot of things from maximum capacity. Is 400 milli matching with overactive bladder? Is it matching with, it's normal. Okay, so I suppose nocturia and mild raising of systolic detrusor pressure in filling phase are distractors to my mind, definitely. And maybe there is some, urgency in the scenario, but the main core of the problem should be SUI. So I have to choose urodynamic stress incontinence. Urodynamic stress incontinence. This is out because of this one. Now, I have C option. I have G again. I don't think with voiding difficulties. I have with sensory urgency. If I'm going to choose, so I will choose the very similar option to the option coming to my mind at first, the mixed incontinence. So I will go for the urodynamic Yes, we'll ask Dr. Hassan. This is my answer. I will go for urodynamic stress incontinence with sensory urgency. It's never overactive bladder anymore because of the maximum capacity of the bladder itself. Now, the sensory urgency, it's not like the overactive bladder. The overactive bladder is a problem with hypersensitivity to the detrusor muscle itself regarding the distension. The detrusor muscle starting to lose the capacity and elasticity and accommodation of distension. But in sensory urgency, patient may have temporary causes of sensory urgency, like some kind of medications. It could be like iatrogenic cause, or it could be also associated with permanent problems like neurological causes for the S. Question 2, better answer is mixed incontinence. Now this is very good question, Manisha. Number one, in exam, it's extremely difficult to find both options in the answer because they are very similar to each other. But if you would like to choose an option, go for urodynamic stress incontinence with sensory urgency. Let me tell you why. The maximum bladder capacity eliminates the possibility of overactive bladder. That's why mixed incontinence is not the ideal option. I mentioned mixed incontinence because I'm trying to act like all of you in the real exam. You will do the same. You will read the scenario. Once you see during filling phase, systolic pressure increased, OAB. Nocturia, more with OAB. And then patient with standing, with coughing, with sneezing, suffer from some drops or leakage. Yes, this is SUI. This is how you all will think in such scenario. But actually, you have to revise your mind regarding the numbers giving in the urodynamics. So yes, I will go for H. What is the capacity, sir? Amna, what do you think? If the normal capacity is from 300 to 500-600, what do you expect in a patient with hypersensitive bladder to any distension? She is going, she is going frequently to the bathroom. The amount or the capacity is definitely less than normal, less than 300 milli, 100%. Now, if the patient with normal bladder capacity, we are most probably talking about urodynamic stress incontinence. If the patient bladder capacity exceeds the maximum possible bladder capacity, we are talking about, yes, thank you, overflow. Dr. Uzma, I saw your hand, so you can open the mic just after I finished this point. It's overflow incontinence. The patient cannot feel any desire while the bladder is, full, okay, and more than full. 700, 800, sometimes 1000 milli in the bladder. Patient can't feel anything. Then suddenly, the maximum vesical pressure exceeds the urethral closure pressure. So the woman will experience gush of urine suddenly, okay? It could be due to failure of sensation, like spinal cord injury. Yes, exactly, Aaron, thank you. Spinal cord injury, like some neurological permanent diseases like multiple sclerosis, sometimes in advanced cases of diabetic neuropathy. Okay, it could be like that. Sometimes after traumatic pelvic surgery, traumatic pelvic surgery. You know, many patients after second stage cesarean section, emergency, second stage fully dilated cesarean section with manipulation of the bladder here and there, dissection, trauma, concussion of the bladder. Patients maybe later on, after the surgery, they may spend time until they be able to recover the whole function of the bladder, sensation and evacuation. So then we need to leave a catheter in those patients for a while. It's called like atonic bladder as well. So all those patients, you will find the bladder volume capacity exceeds the normal limits. I answered your question clearly? I think so. Thanks. So GH. Now, what we learned from this both scenarios, how to read. I need all of you to use the same technique in reading. If you have, you know, many candidates are always sending me asking, Dr. Hassan, the scenarios in EMQs very long, and I spent a lot of time reading, and if I reach the sixth or seventh sentence, I forgot other information at the beginning, so I need to read again. This is a wasting of effort and time. So what you actually need to do is fragment the scenario into small pieces. If you have for example, if you have a major, huge problem in your life, if you just try to face it, you will lose. I'm right. If you just try to face it, you will lose. But if you are smart enough, you can fragment it into small problems and take each problem and manage it separately. Then you will find the whole major problem finished properly. Okay, so fragment everything. Let's go to the second scenario and let's start reading. When we are reading this question, 34 with prolapse, perfect. She can feel something, you know, down below. She has no urinary symptoms except from some frequency. It's not related, most probably, to the prolapse. If the woman has a frequency, urgency with prolapse, most probably this is a urinary tract infection because of the prolapse effect and urine stasis. Now, the cervix descends to the introitus, and there is a second-degree cystocele, anterior compartment prolapse. The perineum and posterior vaginal wall are well supported. That's good. She is breastfed in her third child and delivered 13 months ago and is currently on POPs. Fragment and just tell me, what do you think? I can see, I will take a look over, you know, the options. I like people who are mostly, you know, okay, let's see the answers. B, B, J, F, B. Is there any voice interruption? Amna? F, 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 F. Most of people goes with F. And on which basis? Now we are speaking about B and F, most probably. Am I right? B and F are most of candidates, they are talking to the B and F. So are we going to do a surgery, or we can use the shelf pessary? It's second. If the patient pelvic floor muscle exercise, it will be F, was better. I think you have to utilize every information. Like the patient is still breastfeeding and she is on progesterone treatment somehow. Okay. All of you know that breastfeeding markedly affect the pelvic floor functions. Exactly, Maha. I like this answer, by the way. Okay. So I think this is the first point you need to think about. Second point, why you would like to go for anterior vaginal repair while the patient has no urinary symptoms of SUI or voiding problems. For those friends who choose B, if the patient have a cystocele degree and no symptoms, I will do nothing. Especially she's still young, we don't know the fertility plans, and she's still breastfeeding and taking progesterone. So if the patient is not symptomatic, I will do nothing. I can offer her some exercise. Okay. So it seems like a tricky cystocele is not needing anymore to go for a surgery. So I will go most probably with a pessary temporary treatment for uterine prolapse until the patient is being able to go for maybe exercise, maybe stop feeding. Okay. Everyone, I'm clear. That's good. Okay. What about the 90 years old patient? This is very smart of all of you. I agree. Once I see old frail patient in scenario with prolapse, my mind automatically goes to the colpocliasis. However, she had a prosotentia for many years. Used to take a pessary, but it's difficult to be, used forever. She has extensive comorbidities, so no surgeries. This is what is meant by comorbidities. It means it's not recommended to go for a surgery. Okay. So the question is pushing you towards Le Fort colpocliasis. Am I clear to all of you? Okay. Am I clear? Okay. The last question, she's 57, menopausal, I think. Vaginal lump 20 years after total abdominal hysterectomy for large fibroid uterus. Clinical examination showed significant vault prolapse. 100% abdominal sacrocolpopexy. So what do you think about sacrospinous fixation? Can I go for sacrospinous fixation in this scenario? I have a defected information. Now, this is very important thing to learn. If you have, we don't know, Iram, am I right? We don't know. So if you don't know, is the patient sexually active or not? We assume she's sexually active. So don't choose sacrospinous fixation. Don't choose it. Okay. If the information is not giving, we will go for the default. She's a young age and most probably she is sexually active. So go for abdominal sacrocolpopexy. So this is very important to be learned. The question is, yeah, all of you are great. Old frail patients, we will use pessary first and then go for colpocliasis. Yes, the guideline suggested that pessary is optional for mild. Sorry, Siri. I didn't call Siri. Sorry. No, thank you. Okay. Again, if the patient is old, frail, and she had a mild prolapse, yes, we can offer her pessary option, okay? But if the woman is suffering from significant prolapse and she is old, frail, so we can go for colpocliesis. So number one, it depends on the degree of the problem. Number two, it depends on the patient's wishes. If the scenario said, patient looking for definite treatment, I will go for colpocliesis, okay? If the patient refused surgery, I will choose pessary. Sometimes regardless the degree, you know? So we have many factors in the scenario controlling my decision or our decision. Got my point, Amna? What is decided for the 90-year-old? Colpocliesis is the best definite treatment. And if the patient is definitely unfit for surgery or she is refusing surgery, I can offer her a pessary option. Okay. Here the prolapse is ulcerated. Yes, sir. Why G for question 5? I didn't choose G in question 5, Nazish. I said H, abdominal sacrocolpopexy. Okay. Now laparoscopic. Let's explain this. Why not G? Okay. Posterior vaginal repair. Is there any information given that the patient had a posterior compartment prolapse? No. So why you would like to go for posterior vaginal repair? This is number one. Even if there is no posterior repair, okay, if only sacrospinous fixation, do you have any idea about the sexual activity status of this patient? Is it given in the scenario? No. So I can never assume that the patient is not sexually active, especially she's still young. 57 is still young. So I cannot choose sacrospinous fixation, Nazish. Okay? Thank you. Now, regarding the question of laparoscopic versus abdominal sacrocolpopexy. In this exam, we are following the default original surgery in our options. Okay. I mean, what is the original option for sacrocolpopexy? What is the original option for Birch colposuspension? What is the original option for hysterectomy, bilateral salpingo-oophorectomy? It's laparotomy, abdominal procedure. Okay, so laparoscopic procedure can be done. Laparoscopy carries a lot of benefits, but this is not the original procedure. I will give you a very common example. I said this example to many of our friends in regular course. If you have a case of disturbed ectopic pregnancy with internal bleeding and signs of hypovolemic problems, okay, what is the next step? Laparotomy or laparoscopy? Answer me. All of you said laparotomy. Why? Because this is the original recommendation. But actually, 50% of units in UK, they are managing all cases of...
But if you can do a lot.
Your voice is interrupting, my friend. I'm just waiting for you. All of the time. Last time you did it laparoscopic? You said that? Last time you did it laparoscopic. I heard well? Yes, exactly. This is what I would like to say. More than 50% of units and hospitals in UK, they are now managing all cases of ectopic pregnancy with 2 liters hemoproteinium. By the way, it's easier. You will just insert the camera, insert a suction all of these bleeding, view is clear. I can do it by single port, by the way, okay? So can you choose this option in the exam? No, I can't. Because laparoscopic management is not the default original procedure. You have to go for a laparotomy. So we are dealing with standard options, my friends. So the standard in sacrocolpopexy is abdominal. The standard in ovarian cystectomy, simple cystectomy, is laparoscopic. I can't choose laparotomy, despite I can do it, and so on. Everyone, you can follow me, okay? Am I clear? Dr. Usuru, thank you so much for your valuable input. And it seems like so much confident and smart to do the surgery through a laparoscopy despite bleeding everywhere. Thanks. Thanks so much. And best of luck in your practice and your career. You know that I'm always happy to see you because you have a very good talent in negotiations and smart questions. Thank you. Okay, so we enjoy these kind of questions. Let's move. Let's move more and more. Yes, thank you. Okay, Yasmin, you are right. No, Manisha, we will choose abdominal, even if laparoscopic option is available. Now, let me ask you a question. Just short question coming to my mind. If you have 3 options, abdominal sacrocolpopexy, laparoscopic sacrocolpopexy, robotic sacrocolpopexy, if we are following your vision, I will choose robotic because robotic is the best. Am I right? You know, it's the best option. Least invasive, more smart technique, easier, blah, 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 blah. But we are not following this rule in our answers. We are following the basic option, abdominal. Got my point? Yeah, that's it. Okay. Few more questions. 45-year-old lady complaining of frequency, urgency, and nocturia. Wow. It's like a typical patient for overactive bladder. She is medically fit, but she had 3 normal vaginal deliveries before. Okay. Urodynamics showed, maximum capacity of 350. The trousal muscle pressure, 12. This patient is not OEB. This patient, no way, it's not OEB. How is OEB? How is OEB? Mixed. Mixed means OEB plus leakage, SUI. So is it a case of OEB? Which I should follow the history given by the patient or the confirmed urodynamic results? Which should I follow? If the patient said I have urgency, frequency, and all of this stuff, and then she passed through the test and the test confirmed that the pressure never increased beyond 15 centimeter water, I will follow the urodynamics. I will follow the urodynamics. People are just the history and patient complaints, despite they are very important, but many studies were carried out about the history from different patients. Some patients sometimes exaggerate everything. Some patients sometimes undermining some important complaints. So you cannot depend on history only if the patient passed through a confirmative test. So the bladder capacity plus the pressure at filling phase, which never exceed 15 centimeter water, both findings confirm that there is no overactive bladder. Thus, there is no mixed urinary incontinence. So the positive only finding is leakage with increased abdominal pressure, which is matching with urodynamic stress incontinence. This is a very famous recall, very famous. Unfortunately, more than 80% of candidates in the exam, I saw this by my eyes, they answer it mixed incontinence. This is a very common mistake in the exam. Please don't fall in. If the urodynamics against it doesn't matter. Sometimes the patient had urgency frequency because of sort of UTI. This is not an evident finding. It's a suggestive finding for OEB. If it's clear like this, and then urodynamics should not be conducted. Once it's conducted and confirms against the patient history, please follow. It could be UTI. It could be UTI. I agree with you. But in UTI, I need two things. Number one, no confirmative finding in urodynamics. Number two, the main keyword of UTI is burning micturition. With no burning, no UTI. Okay, for the question. Am I clear? In the exam. Okay, excellent. Symptoms like UTI, but urethral diverticulum, am I right? Urethral diverticulum, you mean, Vanny?
Urodynamics. Urodynamics.
Sorry?
Urodynamics, sir.
Urodynamics. I read it like urethral diverticulum. Yeah. Yes. But urodynamics, like urinary stress incontinence. So I will follow the urodynamics. Okay. By the way, because I remember the urethral diverticulum, the key word in urethral diverticulum is drippling of urine. No drippling, no diverticulum in the exam. Am I clear? No drippling, no diverticulum. 3 Ds. That's great. I like that way. Okay, friends. Question 7. Patient came with... Stop. Let's stop a little bit here. Let's stop a little bit here. Patient came with pain. Now I have to stop because pain is not a regular finding. It's not a regular complaint. Am I right? Pain is difficult. Patients in urinary symptoms can complain of urgency, frequency, nocturia, hesitation, dripping, burning. But pain is very strange. So I have two options actually coming to my mind. Two options. Either bladder pain syndrome or endometriosis of bladder. Endometriosis of bladder. Now, if the patient is infertile, suffering from chronic pelvic pain and dyspareunia, dyschezia as well with the pain and dysuria, dysmenorrhea, so I can think about endometriosis of the bladder. However, sometimes if the patient also offered hormonal treatment and she improves on hormonal treatment, this is a very good evidence of endometriosis of the bladder. If not, I have to think about bladder pain syndrome. Am I right? Pain is we have no options. I mean, coming to my mind with pain rather than this. However, she had cesarean section, taxo frequency, urine analysis normal, as well as urodynamics. She said that her pain directly related to micturition and not relief by it. What do you think? Now I have a problem. Now I have a big problem. With bladder pain syndrome, once the patient evacuates, the patient should feel better. Pain should be relieved with evacuation. So what or why the pain is not relieved by evacuation here or by micturition? Now, it happened before in strategy and in exam. Yeah, in exam. It's the first time was I think in 2016 to express this expression urethral syndrome. The urethral syndrome is typical. Exactly. I saw many people answer it like G. Yes. Thank you so much for your wide knowledge. The urethral syndrome is typical like painful bladder syndrome with only two critical differences. Number one, pain is not relieved by micturition like painful bladder syndrome in urethral syndrome. Number two, there is by examination, palpation, there is tenderness over the whole course of urethra. Pressure on the whole course starting from external meatus upwards. The whole course of urethra, the patient is feeling tenderness and pain by pressure on this course. This is the difference. These are two differences between the bladder pain syndrome and urethral syndrome. It will never come in the exam. I believe in that. But the idea is try to analyze all data carefully. And please, what I'm going to say right now is critical. And this is the main point of difference between good competent candidate and poor candidate. Look at me. Listen. If you find something strange, don't close your eyes and answer what is in your mind just to finish the question and to move. No, don't do that. Now, what will happen exactly with 95% of candidates? Oh, pain. Dr. Hassan said either endometriosis or a bladder pain syndrome. I'm right? Okay. Is there any signs of endometriosis? No. The answer is bladder pain syndrome. I'm very happy there is an option here of bladder pain syndrome. However, the patient related, yes. Oh my God, not relieved by it, not relieved by micturition. This is not happened in painful bladder syndrome. What should I do? Okay, let's bypass this. I think it's painful bladder syndrome. Hey, I will go for painful bladder syndrome. And then you lose the mark. Why? Because you closed your eyes intentionally. Okay? So don't do that. What I'm going to do is, if I am in the real exam and I don't have the information coming to my mind or the knowledge itself, I will do the exclusion criteria. Let's play the game together. Let's play the game. I will show you how to answer questions. This question, there is no mention at all regarding urodynamics or incontinence. Out, 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 out. Okay, these points are out. Now let's move. There is no mention regarding the burning micturition or cloudy urine. UTI out. No low pain, no fever, no burning micturition, no cloudy urine. UTI out. Okay? Now I have two options: painful bladder syndrome, urethral syndrome, and maybe suspected malignancy. Patient is too young, no hematuria, nothing with the risk of suspected malignancy. I suppose this is out. So I have only two options, E and G. Now, not relief by it, impossible to be painful bladder syndrome. I will choose this by exclusion. Okay? This is how I'm going to answer EMQs. Whatever the question is, I will follow the same steps. Try to exclude as much as you can. Let's play the game. You know, let's play the game. Thank you, my friends. You know, you can do this. Everyone can do this. Just train your mind how to exclude most of answers, and automatically you will find it very easy. Yes, this is the ideal way, believe me. You know, all of you, we have actually more than 110 people in this room. All of you have knowledge more than me. Believe me, you are fit, ambitious, targeted, studying for a long time, up to date. All of you are better than me in knowledge. But, you know, if both of us attended the exam, my chances is higher to pass. Not because of my knowledge, because of how to handle the question. And of course, you should be very calm and confident. You know, one of my seniors one day in UK, he told me I was very good in knowledge and I failed first trial. I said, Hassan, you don't need knowledge. You just need to think like this. In SBAs, the first answer coming to your mind will be mostly correct. So choose it. In EMQs, the first answer coming to your mind, most probably wrong. Think twice. And I'm always keeping this information in front of my eyes, because what in the basic structure of the question, single best answer is fashioned to assess one point: knowledge. You know it or not. So deeply inside your subconscious, you will find a lot of informations, but you cannot recall them. But involuntarily, when you read the question in SBAs, the first option coming to your mind, mostly deeply in your subconscious, it's there. It will be correct. Now in EMQs, the problem is EMQs is fashioned to assess knowledge and applied knowledge. So you have to choose an option which is matching with both things. Now it needs twice thinking, okay? Just follow what we said. Now in question 8, you know, complaining of burning micturition. The question is finished here. The question is finished at this point, okay? You will find the bladder capacity less than normal because there is an irritation by infection, okay? There is no leakage because the patient can endure with abdominal pressure. And despite in urine analysis, there is no pus cells, but the positive nitrates is very good landmark for infection. So please go for UTI, okay? That's great. UTI, exactly. Let's keep playing. Keep playing. It seems like a very long scenario, am I right? Yes, a long scenario. I will give you all 10 seconds to finish the scenario. Fragment the scenario. Make it very small pieces and collect data like a puzzle to finish the final picture.
So no audio again. Okay.
I like this way. I like this answer too much. Okay. Patient 60, she is postmenopausal. Okay. She is postmenopausal and she has urgency, daytime frequency, and sometimes nocturia. Okay. It seems like OEB. However, she has no urge, despite the urge is the most common, okay, and no stress incontinence. I mean, no leakage of urine. Okay, OEB can be either associated with incontinence or not. Okay, up till this point, the patient is OEB. Let's go to the second fragment. She has had 3 proven urinary tract infections over the past 6 months. Now here add recurrent UTI. And in recurrent UTI, you have to manage recurrent UTI. I need to stop a little bit here. You have to manage recurrent UTI according to the age of the patient. And according to the frequency of the problem. Is it common or most serious problem? So let's answer these questions together, everyone. Child or teenager patient? Child patient with recurrent UTI. Child, 8 years, 9 years. What is the most common cause of recurrent UTI?
E. coli. Escherichia coli.
I'm against, because the most common is thank you, foreign body. She's too small to have E. coli. E. coli is the most common organism if there is an infection. But actually, recurrent UTI means that the child is playing with something, foreign body, sometimes parasitic infestation in poor countries, but mostly it's foreign body. What about the teenager? Most common. STDs, sexual transmitted diseases, exactly like women in childbearing period. Most probably STDs is the most common. She's sexually active. In old age, postmenopausal, what is the most common? Atrophy, atrophic vulvovaginitis, atrophic urethritis, estrogen deficiency. Yes. Now let's play the game from another side. What is the most serious cause of recurrent UTI in teenager? Excellent. Mullerian duct anomalies. Excellent. Mullerian duct anomalies. What is the most serious cause of urinary tract infection recurrent in child? sexual abuse. Sexual abuse. What is the most serious in childbearing? POI versus STDs. What is the most serious in postmenopausal? Malignancy. Malignancy. Okay, so please differentiate between most common and most serious. Okay, now let's apply these ideas here. Postmenopausal, not on HRT. Recurrent UTI, what is the most common cause of recurrent UTI in postmenopausal coming to my mind? Now the game is changed. This is not an OEB anymore because of the recurrent UTI. Now the game is changed. It seems to be atrophy. Okay. She has 2 vaginal, okay. General condition, okay. And this is matching with that. I mean the HRT. She has grade 1 cystocele, grade 1 rectocele, weakness, atrophic external genitalia. And this is very easy landmark. Otherwise, she's very healthy. Thank you. I will go for topical steroid, topical estrogen therapy. 100%. This is the correct answer. 100%. Everything in the scenario is pushing you towards atrophy. So please keep this option in your mind in exam in 2 scenarios. This is the first one with postmenopausal woman. The second one is lactating woman. Lactating woman with dyspareunia. Lactating woman with vaginal dryness. Lactating woman with recurrent urinary tract infection. And you have to think about topical estrogen therapy in the exam. 100%. Exactly. So if the patient has stress incontinence, then give her topical estrogen therapy. Topical estrogen therapy. Okay? The next scenario. In childbearing age, dangerous cause of recurrent UTI, STDs and POI, premature ovarian insufficiency. Okay. Question 10. 32-year-old woman with 1 child. Okay. When I'm reading the scenario, I'm analyzing everything in my mind. She's young patient, 1 child. So it seems like she is a patient requires fertility. Still, she needs to complete her family. So if I'm either going to give a treatment or a plan or a surgery or something, I need to keep it in my mind. Her GP 1 month history of urine leakage on running and exercise. She has no urgency and her frequency 4 to 6 times during the day, normal, and once at night. So it's most probably SUI. She has no prolapse, bowel, spontaneous vaginal deliveries. Okay, 2 months ago, just 2 months. Blah, 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 blah. General, unremarkable examination, no evidence of prolapse, cervix healthy. What do you think, everyone? D. D is a great option. This is the first option should be offered to any woman with SUI. Additionally, this woman is just have a birth 2 months ago. Okay, so I can't judge the prolapse or pelvic floor dysfunction at least before 6 months after vaginal delivery. So what I can offer her is pelvic floor muscle training. It's easy. I'm right. Easy questions, but just you need to analyze it in a good way. EMQs. What is the next step in management of the following situations? I will leave one of you, anyone, answer question 11. Read the question yourself and answer. A, B, A. A trial of pessary to see if this would help her empty the bladder better and therefore reduce her risk of recurrent UTI. People who choose B, Hina, you choose B. This is the question, the first one in this block, my dear. Okay. Now the options are a lot. So people, do you think, just to, you know, do you think that cystoscopy is important in this case or not? A, E. No, it's not important. I'm right? Okay. Okay. Or it's important. If symptoms persist, I agree with you, Fanny. Cystoscopy is critical if the patient is old age and there is a history of recurrent UTI. Sometimes you have to go for cystoscopy. Okay. I agree with that. So, oh, sorry. I did a mistake. I will okay, again. But, sorry. Okay. From the current slide. Yes, I'm back. I can go for, the trick here is cystoscopy is done with recurrent UTI if there is no obvious cause of recurrent UTI. But if I have a cause for recurrent UTI, so I will not offer the patient cystoscopy. Is it logic? Think again. She has cystocele. Why? There is UTI infection because there is a urine stasis. So if I have a case, she's fine, she's passing urine fine, she's 70, 65, whatever, and she had recurrent attacks of blah, 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 I will offer her recurrent UTI just to discover what's going on inside. But if the woman had an obvious cause, I will go for reduction, evaluation, and re-evaluate the occurrence of UTI. Solve the problem and re-evaluate. I think A is a very reasonable option. Despite recurrent UTI, I may offer the patient a cystoscopy. Yes, I agree with all of you. But if there is no reason, frank cause. Okay, second question. It's the same. She's 65 with history of recurrent UTI. Sorry, it's repeated question by mistake. Okay. Question 13. Now, it's a very young patient age, teen age, referred with history of repeated episodes of frequency urgency pain in the bladder area. When her bladder is full, she had 4 midstream urine samples sent for culture, but none grow any microorganisms. She is severely distressed. A is, sorry, I missed. Yes, A is the answer. I think so. I think so. I will see that still. I don't know. Let me check the marking sheet answer. I will I will check after this question. But I'm matching with, yes. So what do you think about the young age patient? What's coming to your mind? I have some, causes coming to my mind. It may be like STD. Yeah. It may be like chlamydia. Yes. But I think if we went for culture and sensitivity with the urine, the situation will be, confirmed. But actually, culture is free. So I think I need more invasive investigation to be done. Is it cystoscopy? Yes, I will go for cystoscopy actually. But is it outpatient cystoscopy or inpatient with anesthesia? What do you think? This is the question. Inpatient, outpatient, inpatient, inpatient. Now, what is the key of this option? Can anybody read the scenario one more time? Anxious, anxious. She's young, okay? She had 4, she is severely distressed, severely distressed. She is very young. She's anxious. She's afraid. So I will go for inpatient. Full stop. Full stop. Okay? Excellent. Full stop. No options. You got my point? Don't think, I will tell you a very important secret. British people are not generous. Okay? Print, any additional word may make difference. Okay. So I will go for inpatient because of she's severely distressed, and maybe plus or minus biopsy if needed. If the patient had inpatient cystoscopy with biopsy, maybe. Local, no. Outpatient, no. Yes, I will go with F, most probably with F. Yeah, I think so. I can see the options by the way. Yes, the answer is F. F. And the first question, the answer is A. A. Exactly how we all of us choose at the beginning. So A and F. Okay. Elera, it is not. First of all, it's plus or minus biopsy. The second is if you have a case of cystoscopy and there is a picture of petechial hemorrhages and submucosal, bleeding spots, can take a biopsy just to confirm any strange findings. I can do a biopsy for a child if I have some suspicious regarding a certain diagnosis, or I need to confirm some diagnosis. You need to screen, of course, for STDs if the patient is sexually active. Samina, an exam, you have time, but I cannot manage your stress. Now, my friends, let me say something. All of us are stressed in any exam, being very stressed. Now, there is a good kind of stress that makes you alert, makes you ambitious, adrenaline everywhere, waking up, and all of this with slightly tachycardia. This is very normal. Even the person who will be awarded the middle prize of the exam he will or she will suffer from the same problem, the stress, but the positive stress. There is another kind of stress. It's a negative stress, which is associated with loss of concentration, loss of time, afraid. You just feel that you are not competent enough. Please avoid this type of stress and try to think positively. Time is enough. The first trial, my trial, the first one, I spent 3 hours running in each paper. And I tried to cover everything and read the question more than 1 or 2 times just to do my best. I failed the exam. The other trial, when I passed, I finished the first paper in 2:15 hours, and the second one, 2:20. I spent around 45 minutes looking around. I have nothing to do. Why? Because I changed my technique. Okay? So don't say that the time is not enough. Trust yourself. Read questions in the manner we are doing as much as you can, so you can find it, inshallah, easy. What you need to do is training. Just do training. Try to read by the same technique, thinking that way in all your questions and books you are trying to train. You will find then it's becoming like routine way of thinking, routine action in the real exam. Now you will find the difference, the huge difference. Okay? Now, if surgical option there for first patient, best surgical option for the first patient, 100% anterior vaginal wall prolapse management, cystocele repair. It's a significant anterior wall prolapse, so you have to go for a surgery. If the patient refused surgery or the patient is not fit for surgery, okay, we can use some kinds of pessaries. However, the surgery is the option. Question 14. 35-year-old woman with multiple sclerosis complains of urine frequency, urgency, and urge incontinence. What do you think the diagnosis is? E. Excellent. By the way, neurological symptoms for the bladder, it could be associated with hyperreflexia or areflexia. It means it could be neurogenic bladder or atonic bladder. It depends. Okay. 60-year-old developed cervical cancer 12 months ago. She was treated with combined chemo and radiotherapy. She now complains of blood in her urine, which occurs all the time. Wow. All of you are so much experts in urogynae. I like this answer. I like this answer too much. Okay. Yes. The most common cause for bladder fibrosis and bladder interstitial non-specific chronic cystitis, radiotherapeutic sessions and radiotherapy after cancer. Sometimes selective chemotherapeutic agents, but mainly the radiotherapy. So yes, I agree with that. 45-year-old complained initial urinary frequency, urgency, and urge incontinence. There is a leak of urine and also leaked urine on coughing and straining. So she carries both symptoms of leakage, OEB and SUI, treated medically initially, and her symptoms of urinary frequency have largely resolved. Over the last 6 months, she is finding that urinary leakage on coughing and straining is increasingly affecting her social life. Okay. Answer 16 and I will explain 15 later. Now. G. Okay. G. Yes. Most of, please notice that the patient, until this one, this scenario, this is a mixed incontinence. But now the patient is, her problem regarding OEB is resolved. So starting from this is SUI. So the answer is SUI. Okay? Okay. Question 15. Radiotherapy is associated with bladder fibrosis. So patients are unable to tolerate amounts of blood, of urine inside the bladder, frequency, urgency as well. So this is the first complication of radiotherapy into the pelvis. The second one is development of non-specific chronic cystitis after radiotherapy and some certain chemotherapeutic agents. So this is very well matching with these scenarios. The last question in this one. Now, regarding the POPQ, I don't know the POPQ, by the way. I'm depending on, let's go. It's considered the fixed point for pelvic organ prolapse quantification system, POB. The fixed point of measurements. If urodynamics is done, then G, yes. Let's go back. EFA. EFA. Stress incontinence, genuine stress incontinence. I didn't see that, the A. However, one of them, stress incontinence, genuine stress incontinence mean pure stress urinary incontinence, and it should be like it happened alone from the start, solely problem. Stress incontinence can be associated with OEB under the name of mixed incontinence. Urodynamic stress incontinence is the confirmed stress incontinence by urodynamics. So again, if the primary original problem solely happened with stress incontinence, it's genuine stress incontinence. Stress incontinence itself could be associated with OEB in mixed, and it's a clinical diagnosis. If the clinical diagnosis is confirmed by urodynamics, now the diagnosis is urodynamic stress incontinence. On the other hand, the clinical diagnosis of urge incontinence or OEB, named like OEB, overactive bladder. If the patient undergo urodynamics and it's confirmed, the terminology of diagnosis will be detrusor instability or detrusor overactivity. By confirmed urodynamics, the diagnosis is not OEB anymore. It's detrusor overactivity. What is the fixed point? Yes. B. Hymenal ring. Yes. Hymenal ring is the fixed point of measurements of pelvic organ prolapse quantification. Now, on the POPQ system, what is the point which indicates cystocele? It should be like in the anterior wall. Okay. So I need to look forward point A. Am I right? Point A. So it seems like point A less than 3 centimeters above the hymenal ring. less than, or point A or C less than 2 centimeters above the hymenal ring. It's AA. There is no C. C is the cervix if presented, or C is the vault if the woman removed her cervix and uterus. So A, we are looking for A, and in -3. I think the point H, AA, is the best one. Okay, it would be nice to have the, let's see. Your dreams are always welcomed, my friend. This is the POP-Q quantification. Okay. So point A is, yes, point A is referring to the anterior vaginal wall. Point B is posterior vaginal wall, PP for posterior, A for the lower half, AA, BA for the upper half of the anterior wall, as well as AP is lower posterior, and BP is upper posterior. Okay. Hymenal ring here is the matching point for measurements. C is matching with the cervix, and D is the highest point with the vault. Okay. So if we have a prolapse, okay, cystocele means anterior compartment prolapse. What do you think the answer should be? Let's see again. Surprisingly, let me explain this. The AA is the lower part of the anterior vaginal wall, while the BA is the upper part where the base of bladder will be descended through. So in cystocele, point B, A, is the major part of defect. BA is the major part of defect. Is it clear? Okay. Exactly. Exactly, Aaron. Okay. On the POP-Q system, the point which indicates vault prolapse. Vault prolapse. D. Yes. Point D. And this is an easy thing and very famous thing. Okay. Now, before going to another presentation, I will give 2 minutes of rest. Go here and there, drink something, move your legs, wash your face, and refresh your mind. Let's keep our job. 2 minutes, nothing more. And then we will be there. Thank you all. Now we are back. I saw in the chat room some people are asking about the key of the last questions. So this is the key of the last question. Again, the fixed point of measurements of the prolapse in POP-Q is the hymen. In cystocele, it's BA. And the point of referral to volt prolapse is point C. Point C. Okay. Okay. Am I clear? Point C. This is the key. Yes. I offered it. Yes. Yes, of course. C is referred to cervix. If the cervix is removed, so the D, which is the volt, will be C instead of the removed cervix. D, yes, if the cervix is still in place in non-hysterectomized woman. Okay. Which slide? This one? Okay.
Sir, please, sir, explain with this slide. Sorry, sir, please. Sorry for taking you back. Can you explain these points well with this slide? Now, it's better here now. I'm sorry to take you back, sir.
Okay. Okay. Now again, just a revision. This is the anterior wall. Let's choose another one. This is the anterior wall of the vagina. And it's classified into upper part and lower part. AA is the lower part. BA is the upper part. The BA is related in contact to the bladder itself. So if there is any herniation of the bladder in the vagina, it means that point BA is defected. Okay. The degree of the prolapse is depending on the relation to hymenal ring, which is the fixed point. Now, the posterior wall is also classified into PAP posterior A, P for posterior B, upper half and lower half, or upper 2/3 and lower 1/3. C is mentioned the cervix, and D is the highest point referred to the volt. Now, if the patient is hysterectomized, there is no cervix anymore. Okay, there is no cervix anymore. So the point D will not be there, and the volt will be point C. So volt prolapse after hysterectomy, point C is prolapsed, not point D. Okay, D for volt is if the woman is not hysterectomized, the cervix is still in place. Okay. And this is the question slide.
Thank you very much, sir. Thank you.
Thank you. Rectocele is point BB. Answer slide. Okay. Now, I will go to change the minds and discuss different topic. Let's do it. Everyone, try to do your best. If you have an EMQ like this with different kinds of tumors, and we are just asking for the keyword pathological or ultrasonographer or imaging keyword to identify this tumor. What should you do in a large cell tumor of the ovary? Androgen secreting tumor. of the ovary, which was resected, okay, from a 30-year-old woman, abnormal androgen metabolism. The pathological examination revealed tumors moderately differentiated within the cytoplasm and nuclei of the cells. There were several rod-shaped crystal-like structures. And what does that mean? Which expression of the options matching with these histopathological findings? A, Rinke's crystals. Rinke's crystals are the landmark of Leigh-Sertoli cell tumor. You are afraid and scared from long scenarios. So Yasmin, you have to, again, break it down into small pieces. Read it in small sentences. You will find it very easy, okay? Euxac tumor with the ovary resected. Examination showed presence of rosettes of tumor cells around blood vessels. Anybody knows? Schiller-Duval bodies. All of you are great indeed. Indeed. Okay. The first one is a woman with total abdominal hysterectomy, oophorectomy of premenopausal bleeding, postmenopausal bleeding. Preoperative ultrasound scan showed the presence of multicystic lesion on the left side of the ovary. However, there's no ascites. You answered it. I'm still reading. Now this is great. Normal tube. Histopathological shows endometrial hyperplasia. The lesion on the left ovary is hemorrhagic, composed of nests of granulosa cells. There was space-filled eosinophilic hyaline. What do you think? J. Kohl-Zinner. Kohl-Zinner. What is the name of the tumor? Granulosa cell tumor. Granulosa cell tumor. Estrogen secreting tumor because of endometrial hyperplasia. Please notice that granulosa cell tumor is a very beloved tumor in the exam. It comes in extremes of age, exactly, juvenile and postmenopausal. And most probably postmenopausal patients will suffer from postmenopausal bleeding. Yes, thank you, Iran, thank you. In young child patient, it may represent with precocious puberty. Precocious puberty, okay? Keep it in your mind. What about the Samoma bodies? Samoma bodies are classical ultrasound finding of calcification and projections in serous, papillary serous epithelial ovarian tumor, okay? Yes, exactly. That's great. Please remember, epithelial tumors are the most common origin of ovarian cancers. 90% of ovarian cancers are epithelial in origin. Serous with Samoma bodies, mucinous, very large size, and associated with appendicular lesion. Yes, even in borderline. Yes. Clear cell carcinoma is preceded by endometriosis. Endometriosis is associated with development of clear cell carcinoma, high risk, hobnail appearance of cells, excellent. And endometrioid ovarian cancer, it's very similar to endometrioid origin of endometrial cancer with concomitant 43% patients with endometrial carcinoma, okay? This is critically important question. A, G, J, perfect. Take a look over this table, please. Hobnail cells, excellent. Okay, and Krukenberg tumor, the secondary carcinomas of or secondary malignancies of the ovary, is associated with signet ring cells because it's most probably arising from GIT tumors. Okay, excellent. Fleshy is this germinoma. You mean fleshy tissue? This germinoma is the most common, the second most common, yes, germ cell tumor. It's fleshy in nature. It's the only ovarian cancer which is radio sensitive, the only one, okay? And the tumor marker is lactate dehydrogenase, LDH. This is the tumor marker of this germinoma. You are right. Next. Now, what is the best, I think, next step in evaluation, like investigation or biopsies? 73 patient, okay. Routine recall of her lichen sclerosis. It's a precancerous lesion of the vulva. Mentions itching, okay, worsening at night, suggested treatment. She also mentions she has some swelling down below that feels like the size of 10 pence coin. She is referred to the hospital on examination, noted raised ulcer with rolled edges. Her examination is normal, no groin, nodes palpable. A biopsy is taken under a local anesthesia in clinic. In anticipation, what should be arranged? What should be arranged? B, I agree. I agree. A biopsy taken under local anesthesia in clinic in anticipation, what should be arranged? I think by exclusion, you can reach also the diagnosis. By exclusion, B seems the most logic one because she is at the, you know, just followed up by the GP and GP referred her. I think so. 72-year-old patient is seen in Urogynaecology clinic, complaining of BOB. History of intermittent steroid cream use for soreness and itching vulva. On examination, there is a warty lesion on the vulva on the left inferior aspect of labia majora. Now, I think B is the answer. Because she's in Urogynaecology clinic. Okay. What do you think, everyone? I think at this point we need to offer her. She is in Urogynaecology clinic. Okay, because of BOB. So it's better to refer her to the vulva clinic first, and there they can take the decision to take a biopsy, yes or no. So I will go for B. Now, stop. Let's talk about very important thing. Very important. Sometimes in the exam, you have to believe that you will find questions, a little bit questions, that it's very difficult to be answered correctly. So don't let these questions break you down or making you unconfident, because difficult questions for you definitely will be difficult questions for others. And if they are difficult, most of candidates will miss them. So they will never make a change in the competition between you and others. What really makes change in the final mark is the regular questions, the easy, straightforward questions. If you do them wrong and everyone do them correct, now the competition is against you. But in difficult query questions, they will be always difficult for all candidates, and percentages of mistakes are very high. So if you lose the question, I will lose, all people around you most probably will lose the question. This question will never do a major change in the comparison and competition. You all got my point. So don't let query question or difficult questions like break you down. This is the first thing. I muted everyone. This is the first thing. Think about what I said logically, you will discover that I'm true. The second thing is, you read the question number 4 and question number 5. Okay, so 4 and 5. You are so much unconfident regarding the answer, but you are sure that one of the 2 questions, the answer is B. Okay, you are sure one of them is B. In the exam, put both of them B. Both of them. Okay, listen to me. If you are sure that one of them should be B, now you will be confused. Let me do B in question 4, and let me find another option in question 5. Or let me choose B in question 5 because I'm sure about that. And again, she was at the GP and here in the clinic. I will choose B in question 5, and I can choose A for question 4. Now you start to think, okay, but you are not confident. I will choose both questions with B answer. Now I am sure that I gained 50% of the mark. 100%. I gained 50%. I will gain 1 out of 2 marks. 100%. Okay. If you try to think, you may lose the both questions. Both questions. Am I clear, my friends? I'm telling you some points that is not related to the knowledge, not related to the guidelines. I'm giving you some options in the exam that if you have some problems in reading questions or understanding, or you are not confident with the answer, don't do silly mistakes. Lose 50%, but ensure 50% of the mark. This is definitely better than losing 100% of the mark. Okay? If I am in this exam, I will choose both questions B. 4 and 5. I don't know the marking sheet. What is it? I will choose both B. Whatever happened, I'm happy. One of them, 100% correct. Let's see question number 6. Maybe I will choose the 3 options B. Let's see. 70-year-old presents via an urgent referral with a 4-month history of vulval pain. There is a lesion, 4 centimeter irregular exophytic tumor replacing the clitoris and extending to within 15 millimeters of enlarged lymph nodes are bulbable both groin. Thank you. This is a definite vulval cancer. Definite vulval cancer. So I will go for a biopsy, I think. I think I will go for a biopsy. Arrange excision biopsy? No. I will go for wedge biopsy. Most probably. Yeah. Okay. Why? Because of the size. Because of the size of the lesion. I can't do excisional biopsy. Okay. This is not the recommend. Yes, why? Excisional biopsy only offered if the maximum diameter of the lesion never exceed 1 centimeter. If the lesion is higher than this in size, the maximum dimensions, I will go for incisional biopsy, because I don't know if I remove the lesion, what is the ideal depth to remove, and what is the ideal safety margin to be given. Okay. Sometimes I can't go for excisional biopsy because of the location of the tumor. Okay. The patient with clitoris, okay, the lesion, how can you go for excisional biopsy? You will do clitorectomy. Am I right? This is extremely difficult. You know, it's impossible, not recommended. I will do the wide local excision, but not under the local anesthesia, and it will be done by a team. So the biopsy is different. The biopsy, yes, exactly. Go for a biopsy, incisional biopsy, because the size and the site of this lesion, if the size is less than 1 centimeter diameter, small lesion, I can do it. And if the size, for example, is, sorry, if the site is left labia majora, right side, you know, near the fourchette, I can do excision if it's small lesion. But some areas should never go for excision, like clitoris or midline lesions. Okay, so this is how can you judge either to go for wedge biopsy, incisional biopsy, I mean, or let's see. Oh my God. AEE. So the only answer correct is E. Let's see what is the answer. A. I believe that number 1 should not be B, but number 2, it should be B. They choose wedge biopsy of the lesion. Okay. Let's revise the question again. I'm unhappy with that. The patient is in urogynec clinic, my friends. Okay. Urogynec clinic. On examination, there is a warty lesion of the vulva. So of course, I'm not happy with that. It should be B. I think I need to refer the patient for a vulva clinic because she is definitely in urogynec clinic. I think this is a mistake. Question number 1, the patient already, you know, the biopsy was taken already, so no need to go for a biopsy. And before going to any advanced surgery, we can prepare the patient for investigations and distant work, like preoperative routine work, because of her age. Okay, I can accept A as an answer here, but I will never accept E as Sorry? Sorry? I think the mic is open at some of our friends. Okay. So I will accept B here, 100%, and I will accept E here. Okay. So A, B, E. This is the ideal, I think, option. What do you think, friends? Please mute. Yes, I did mute myself. Sir, question 5, I will go for B. No biopsy done in question 5. Yes, but the patient's in urogynec clinic. So because she suffered from pelvic organ prolapse, they discovered accidentally a vulval lesion. So she should be referred to the gynae-onc vulva clinic. Got my point? Diagnosis is not yet confirmed. What should be anticipated? I will go for the only possible option, is the investigations. Can't we take biopsy, sir? In which question, Irsa? In question 4, biopsy already taken. In question 5, we will take biopsy, but in gynae-oncology clinic, not in urogynae clinic. Okay, this is the argument. Okay, so that's why I will go for wedge biopsy in the second. Sorry, I will go to refer question 6. Why not H? Because you need to investigate the lesion here. It's urgent referral. Okay, so you need to investigate the lesion. The only investigation for any lesion like this should be why not B? Because the patient is already coming in urgent referral to the oncology clinic. Urgent referral means you are now in oncology clinic. You cannot be refer here anymore. Okay? Think about this a little bit. Am I clear? Please move. I'm sorry. I'm sorry. I will move right now. I'm just trying to explain everything. AEB. Yes, this is the key. ABE. Okay. Question 7.
Sorry, excuse me, sir, Dr. Hassan. Sorry, please.
Yes.
I hope in the recording we are going to get the keys boldly written so that it will be easy for revision, sir.
I can send you the presentation overall. It doesn't matter.
Yeah, that's what I'm saying. Like as we are answering them, so it's easy for us. And with the BCC, all those things, so that it will be there like that. Thank you very much.
Yes, I will send the whole presentation. It's yours. No problem, my friend, for all of you.
Oh, thank you very much. Thank you very much.
You are so welcome. Thank you. Okay. The postmenopausal woman has, this is critically important. This type of management of postmenopausal ovarian lesions, simple cysts management, complicated cyst, high risk RMI, low risk RMI. This flow chart is 100% coming in the exam. So keep it in your mind. 4 centimeter in diameter, which is not changed after 2 scans. Okay. 4 months apart, CA125 is still low. How can we manage? Now, just to remember, I will revise it rapidly. Patient, postmenopausal, CA125 transvaginal ultrasound. If RMI is than 200, it's low to moderate risk. If higher than 200, I will do CT scan, tertiary center referral, MDT, staging laparotomy. Okay, what about the low risk RMI less than 200? If the patient fulfilling the criteria of accidental discovered, it means asymptomatic patient, less than 5 centimeters diameter, simple criteria, unilateral, unilocular. If these criteria are fulfilled, I can offer the woman follow-up. 4 to 6 months, I will repeat the transvaginal ultrasound CA125. I have 3 options. Either the cyst is resolved, discharge the woman, or the cyst is persistent, I can repeat one more time, the follow-up, or the cyst is enlarged, so I will go for a surgery. Okay? Now, if the cyst is persistent like this, I can repeat another scan up to maximum 2 scans. Okay? If it's the same or increased, I will go for laparoscopic bilateral salpingo-oophorectomy. Laparoscopic bilateral salpingo-oophorectomy. So the woman here is already not changed after 2 scans. She used her chances of follow-up. She used her chances of follow-up. Postmenopausal, yes. Okay. So if there is no change after the 2 chances, I should offer bilateral salpingo or oophorectomy. Okay. Perfect. Number 8, postmenopausal woman has ovarian cyst 4 centimeters, which causing lower abdominal pain. Otherwise, no significant ultrasound scan findings. Now, this is not fulfilling the criteria. It's not asymptomatic. It's not asymptomatic. It's symptomatic patient. So go for bilateral salpingo oophorectomy. Straightforward. Please revise this clearly and carefully. Okay. The third one is postmenopausal woman has ovarian complex cyst. Complex. It's not simple anymore. 4 centimeters which causing lower abdominal pain, ultrasound, rim of free fluid in Douglas pouch. And, you know, CA125 is borderline normal. Okay. What should we do? Okay, F, total abdominal hysterectomy, bilateral omentectomy. What about the option K? Is it possible? What do you think? Is it possible? H. A, H. What do you think? (9K), proceed for full laparotomy. Rasha said it's H. I'm agreeing with, no, I'm agreeing with K. Go for staging full laparotomy. Staging full laparotomy. Because this patient, okay, now let's think a little bit. How can you answer this question? Can you calculate the RMI for me? Can you calculate the RMI for me? Calculate. Mohamed Abul Wafa, please calculate on no basis. Yes, it's definitely, okay, less than 200. So I am in need to go for staging laparotomy? No, I'm sorry. I'm not in need to go for staging laparotomy. So total abdominal hysterectomy with omentectomy is not the option. Okay, it's not the option. So it's mild to moderate risk. Why I didn't choose bilateral salpingo or oophorectomy laparoscopically? Why? Because it's complex cyst. That's why I will go for H, total abdominal hysterectomy, bilateral salpingo or oophorectomy. Why it's 315? Why? It's 3 multiply 3 multiply 35. Complex cyst. It means no, not simple clear. It means, is there any finding like locularity, bilaterality, solid projections, anything, any feature rather than the rim of free fluid? The only finding is rim of free fluid. The complexity doesn't mean that we have two features. Tell me the two features. RMI, you should find 1 of 5 or 2 of 5. Bilaterality, ascites, okay? Presence of projections, okay? So 1, 3, 35. Just if you have problems in management, multiloculated, there is no mention for that. It seems like the background is not jet clear black, like heterogeneous fluid inside. This is complex cyst, okay? So once you have a problem with questions like this, you have to, it could be like hemorrhaging cyst. Hemorrhaging cyst is complex cyst. Am I right? So once you have a problem in such scenarios in exam, please calculate RMI carefully and choose the ideal option accordingly. Okay. Now the beloved questions regarding the cervical screening and colposcopy and all of these stuff, how to manage. 30-year-old woman, recent cervical smear shows abnormal endometrial cells, probably of endocervical origin. Is it normal to find? Is it normal to find endometrial cells in cervical smear? Normal. Yes, normal. Less than 40 years, it's normal. So nothing, please. Reassure the patient and no action needed. Next. If you find the same question, and the patient is 50 years, what should you do? Don't know. Before biopsy. What should you do? No. Please go for transvaginal ultrasound scan to assess the endometrial thickness. It's very logical. Am I right? Thank you so much. This is the answer. Okay, so the age of the patient makes difference. Question 11. 19-year-old with 2 episodes of postcoital bleeding. Wow, she's 19. Okay, she is 19. She's using COCs. What should we do? What do you think? Agent PMI. I. Cervical smear. I. J. No action needed. What is her problem? What do you think? Is it cervical cancer? What is her problem? Infection. Thank you. Stop. Ectropion. She's using COCs. This is the game. Your eyes should translate everything. Very common with COCs. So actually she is suffering from ectropion, a very benign thing. Okay, so we can either choose to send her to the gynae clinic for two reasons. The first one, management of ectropion and follow-up. The second cause is they may offer her swabs to exclude STDs. Okay, so it's better to send her to the gynae clinic. Okay, this is about the diagnosis. Perfect. I liked your way of thinking, everyone. You are extremely fine and good candidates indeed. Question 12, age 41, previous LIDs show CIN3 and CGIN with complete excision of the lesion. Then repeat smear shows normal squamous transformation zone seen age 41. Yes, this is this repeated scenario. So The patient had CIN3, CGIN with complete excision of lesion. Repeat cervical smear shows normal squamous, but no TZ seen in colposcopy. What should you do? Any additional thing? A, recall in 6 months. Test of cure with HPV in 6 months. I think this is an old question, so most probably you will find the answer different. Okay, let's see the answer. JKN. What is the answer in? Repeat smear in 3 months using ECTO and cervical sampler. This is an old question. No, the answer is test of cure 6 months later. Okay, by HPV, if the complete excision is done for the advanced lesion. So this is the answer. Next, 75-year-old, some vulval discomfort, no evidence of skin changes, but palpable vulval lump lying towards the posterior part of right labia majora. It feels like a solid lesion around 2 centimeter diameter in the position of right Bartholin gland. Recall 6 months, sorry, a test of cure in 6 months with HPV. Answer A. Shazia, MGZ, friends, please read the question properly. Is the lesion a cystic lesion or solid lesion? Answer me. Is it cystic or solid? Okay.
Yeah, solid.
So it's always in front of your eyes, but you have to catch the point. How it's solid, and then you offered me an answer of Bartholin cyst. It's unlogic. Am I right? So it's a primary adenocarcinoma of the Bartholin gland. No problems. No. I like everyone to do mistakes here. Then you should avoid these mistakes in the real exam. This is the aim. So it's always there. Be careful. Okay. Now again, the next question. 54 years old presents with vulval irritation. She has 3 small areas of skin with brownish discoloration. Coming to my mind directly, melanoma versus VIN. Okay. No ulceration. You excise one of these areas as a representative biopsy. What coming to your mind? The answer is very easy. What are pigmented lesions you know? What are pigmented lesions you know? Melanoma, VIN. Am I right? Lichen planus is pinkish reddish lesion. I will explain all of them rapidly. The answer is L. I mean, no. Irsa, question number 14. We are in question number 14. So it's VIN. Now, question 15. 27, red raised lesion on the right labia. It's tender to touch and has an umbilicated tip. Straightforward. Molluscum contagiosum. Umbilicated tip. Single raised lesion. Lichen planus, never single. It's multiple pinkish reddish papules or plaques should be associated with buccal ulcers. I'm right. You catch my point? So let's go through the options. This is the best way to study. Okay, A, B out, Squamous cell carcinoma is clear, like maybe an ulcer or exovetic mass with areas of hemorrhage and necrosis. Lichen planus is recording will be sent by tomorrow morning to all of you. Don't worry about that. Lichen planus, pain more than itching, papules, plagues, buccal mucosa, affection, Wickham pattern, PP, pattern, Wickham stria, P, thank you. You catch the point. It's all P's. Lichen sclerosis, all of you knows that. Whitish lesion. It's not reddish, okay? Whitish lesion, atrophy, fibrosis, dyspareunia, cigarette paper, okay? Condyloma acuminata, it's multiple infections in the groin with positive nodes, inguinofemoral nodes. Molluscum contagiosum, viral infection, raised single amplicated tip lesion. Adenocarcinoma is well known. Hyadenoma, hyadeninitis suppurativa. Okay, it's multiple lesions like folliculitis and abscesses, draining lesions everywhere. Very difficult to be treated. Endometriosis is not in the options too much in the vulva. VIN, warty lesion sometimes with HPV-16, multifocal, multi-centeric, brownish or pigmented lesions. Psoriasis, discrete, non-scaly, reddish, pinkish lesion. Herpes, painful, scattered blisters. Urine retention reflex. Pexid, equal, very similar to lichen planus, but additionally, the patient have ocular ulcers. So Pexid, oculo-oro-vulval ulcers, while lichen planus, oro-vulval ulcers. This is how can you remember the keywords of vulval lesions. Okay? Very good revision, by the way. Which the flashcard on these? I didn't catch your point. Key again? Okay. I will send you the whole presentation, my friends. Don't think about the keys. It's easy one. Okay? I will send you the presentation. You can read it more time.
Yeah, that's better, sir. Dr. Hassan, that's great. That's better. We prefer that. Thank you.
Thank you. Yes, thank you. Question 16. 62 years old presents with irregular vaginal spotting for several weeks. Okay, it means like resistant or recurrent attacks. 2 years, she was investigated for similar symptoms by hysteroscopy and biopsy with negative results. Okay. She has been taking Tipolone for 11 years. A recent ultrasound scan has shown normal pelvis with endometrial thickness 3 millimeters. What is the best thing can be offered in food menopausal management? Any suggestions? G. Estrogen. J. Only one person. Do you think that this patient suffering from atrophic endometritis, while she's taking HRT Tipolone, do you think so? Oh, I don't think so. And then as well, I can't judge the endometrium while the patient is on Tipolone or oral HRT properly. So I need, if I have a reason for the bleeding, I need first to, she has uterus, no estrogen. Okay. So I think we need to go for discontinue HRT first and then evaluate. Atrophic vaginitis is not a cause for postmenopausal bleeding. Okay. H. B. You choose B, while B starting with TV scan. Woman already did the TV scan. So TV scan is out. Why not K? K. Treat with cyclical progesterone. Now, we have a very important rule in this exam, my friend. Very important rule. Never to give any hormonal treatment on unexplained bleeding. Full stop. Never to give any hormonal treatment on unexplained vaginal bleeding. Postmenopausal bleeding, up till now, it's unexplained for me. I don't know why. So I will try to exclude causes. Patients taking HRT, stop HRT and reevaluate. Full stop. I'm pretty calm because endometrial thickness is just 3 millimeters. Okay. And it's very difficult to be atrophic endometritis because patients is on TPOL, on HRT. So most probably, I need to exclude HRT cause, stop it first. You have a problem. You have something obvious, okay? Please remember that HRT is the second most common cause of postmenopausal bleeding after atrophic endometritis, okay? So just try to stop first the obvious finding in the scenario. 51-year-old, her last menstrual period 9 months ago. Okay. 3 weeks ago, she had some headache, breast soreness, and after a few days, vaginal bleeding for 4 days. She's up to date with her smear and physical examination reveals normal findings, but her BMI 39 and she has hypertension and type 2 diabetes. Transvaginal scan. Perfect. The patient should be offered transvaginal scan. Okay. So what about B? B is a good option as well. Transvaginal scan, then hysteroscopy or endometrial biopsy. But up till now, I think I will go just for transvaginal scan directly. Okay. Okay. B is more good because she had, yes, this is what I'm thinking in. Let's think one more time. B is better option because patient carries at least 3 risk factors for endometrial cancer: hypertension, diabetes, PMI. It carries a lot of risk factors for for endometrial cancer. So now, you know what will be, yes, do you know what will be the key point to answer this question in the exam? Do you know what will be? The headline of the question. If the headline said, what is the most appropriate next step? Answer is A. If the head of the question said, what is the best plan of management? The answer will be B. Everyone, you understand me. You catch my point. The next step, the initial step in management, ultrasound. But the best plan, yes, I will do ultrasound scan. If I have problems, I will go for hysteroscopy, not PIPEL, and we will think about endometrial sampling. That's it. So please read the headline properly. This is critical. Okay. Yes. 67-year-old was diagnosed with breast cancer in, I don't know, however, and has taken tamoxifen, risk factor for endometrial cancer, 6 times. 3 months ago, she presents with postmenopausal bleeding and found to have endometrial thickness of 12 millimeters. Hysteroscopy shows thickened endometrium with no polyps, and biopsy showed complex endometrial hyperplasia without a tibia. Her oncologist changed the medication and to another one, and she has had no further attacks of bleeding. What do you think? Ugh. What's coming to your mind in options? C, total abdominal hysterectomy, bilateral salpingo or oophorectomy, major endometrium. C, endometrial biopsy. She already had the endometrial biopsy, my friends. Already had the endometrial biopsy. Okay, so C is out. I saw somebody said Mirena. No way to give her Mirena while she is a patient of breast cancer. We have a deal, my friends. No hormones anyhow with breast cancer. Yes. So let's play the game of exclusion. Transvaginal out, B out, C out, D out. Let's think about E. Okay, let's think about E a little bit. It could be an option. Okay, what about F out, G out, H out, hook abdominal, pelvic CT scan, and CA125? Why? We have no problems with the ovaries. Now the patient is stable already. Prescribe short course of local estrogen cream or pessary. I don't think so. Treat with cyclic progesterone. I don't think so. So what should be the answer? The answer is C. Any explanation for this answer? Yes, I'm asking, any explanation? C is already done. C is already done. I will go with E. Yes, this is a wrong key. I will go with E, my friends. E. C is already done. This is very logic. Okay. So the best option from all options given will be E. The patient with repeat biopsy then mean biopsy done and complex is for E. Exactly. This is what we should do for this scenario according to the guideline. It's without a tibia Samina. But yes, the best option is if the patient doesn't require fertility anymore and she's a high-risk patient, so you have to go for removal. So the best answer from options is E. In EMQs, we have some problems in the real exam, and this is obvious. Candidates are looking for the typical, okay, the typical answer according to the guideline. But actually, this is the applied knowledge. You sometimes may not find the typical answer, okay? But you have to think about the best alternative action, okay? The best alternative action. We have one more question, 7, EMQ 7, okay? Staging. Rapidly, move. The uterus contains fleshy tumor, 2.5 centimeter in diameter. This is well-differentiated endometrioid adenocarcinoma invading myometrium over 50%. There is no extension anywhere, and peritoneal washing contains no malignancy. Stage 1, not 1B, okay, 1B, 1B1, thank you. 1B, G1, I agree. The second is the right ovary is enlarged and cystic, measuring 9 centimeter in maximum diameter. It contains solid tumor, 2 centimeters, unilateral. Okay. The tumor is clear cell carcinoma, which does not breach the ovarian capsule, but is within centimeter of its one point. There is a breach in one point. The uterus, cervix, left ovary, all free. Momentum is free. Peritoneal washing contains clusters. I'm sorry. Now it's changed. What should be? 1C3. Which G? What is the grade? It's 1C3. Which grade? Is it high risk or low risk? G1, G2, or G3? It's 1CG3. 1C3, G3. It's high risk because it's clear cell carcinoma. Thank you. Thank you. Excellent. Excellent indeed. Okay. I will send the presentations. I will stop here. I will send the presentations, and I just would like to say something. I'm so happy and proud of all of you. Your level of knowledge, thinking way is really respectable. And the aim of this session today, it's not just to give you some questions or giving you some keys. It doesn't matter for me, okay? My main issue is reformat your brain towards how to read questions, how to analyze questions, and how to solve problems when you are unconfident with many topics. This is the game in exam. So thank you so much for being with me in this session. I'm really proud to be with all of you. I will keep prayers. Pray for me. I have a lot of things to be done next week with part 3 exam. Wish to see you all in part 3 exam very soon, because everyone in this room deserves success and happiness. God bless all of you. Best of luck. Enjoy the progressive course. Best of luck. Thank you, friends. Thank you. Thank you. Have a nice